Hello, everyone. On behalf of the Egyptian Association of Pediatric Ophthalmology and Strabismus Board, we're pleased to welcome you all to the first joint webinar between the EAPOS and Bascom Palmer Eye Institute. We'd like to thank Novartis and RM for sponsoring this event, and I'm honored to be moderating this special meeting, myself, Dina Hossam, Assistant Professor of Ophthalmology, Cairo University, along with my dear colleagues, Dr. Ayman Elghonemy, Consultant Pediatric Ophthalmology, Memorial Institute of Ophthalmic Research, and Dr. Mohammed Saeed, former Assistant Professor of Ophthalmology, Bascom Palmer Eye Institute. And according to Miami time, good afternoon, Dr. Mohammed. And according to Cairo time, good evening, Dr. Ayman.
Good evening. Good evening, Dr. Dina. Thank you very much for this introduction. I'm very glad for having this meeting. Tonight we are honored actually to have with us Dr. Tajam Peter Chang from Bascom Palmer, and Professor Dr. Hala Elhilali from Cairo University, and Professor Dr. Nihal Elshakankiry from Alexandria University, Egypt. In this meeting, I would like to first welcome all the audience with us, and I'm encouraging them really. Please, we will be happy to have your participation. You will have a button. There's a button called Q&A for your questions. There is a chat button, but we are really encouraging you, if you have a question, to put it in the Q&A. So this question will be collected and introduced to the speakers to listen to their answers. Also, we will introduce some polls. And we are really interested to know the opinion of all the audiences about the topics that will be raised in the poll. So please be ready to, all of you be ready to share in the poll and in the question and answer section. And we are interested to start the first poll. If you can just start the first poll now, and please concentrate and tell us about your answers in the poll. So for the IT team, please, would you please introduce the first poll? Yes, thank you. We have two questions. The first question for the audience: do you perform pediatric cataract surgery? Yes, quite frequent, or yes, but infrequent, or you never do it, you just refer it. The second question is, when you do pediatric cataract surgery, your routine technique is anterior approach or posterior approach. So please, all of that in these, all the audiences, please share your opinion. Now, Dr. Mohammed Saeed, you can start talking until we receive the answers from our audience. Dr. Mohammed, my friend from Miami.
Thank you so much, Dr. Ayman. It's an honor for me to join this panel of expert pediatric ophthalmologists and pediatric cataract surgeons in both Egypt and the United States. This meeting will basically be split into three more or less equal parts. The first part, each of our three speakers is going to share with the audience their technique for basic cataract surgery in children, what they do in the routine surgery. The second part will be a discussion of issues that had been raised during the first part of the conference, and we will also be answering selected questions from the audience. The third part of the meeting is going to be presentations from our three speakers on a selected topic that is advanced or complex situation that they do cataract surgery in children in. And it gives me a great pleasure to introduce Dr. Tajam Peter Chang. Peter is actually my mentor in both my pediatric ophthalmology and glaucoma fellowships. He's an associate professor of clinical ophthalmology and pediatrics at the Bascom Palmer Eye Institute, University of Miami Miller School of Medicine. Peter's practice grew to become a tertiary referral center for children with cataract, glaucoma, anterior segment, and other genetic disorders of the eye, not only in the United States, but really internationally as well. He's a master surgeon, and he's a perfectionist as well. He's the founder and currently in charge of the wet lab surgical training curriculum at Bascom Palmer, and is one of the most popular surgical mentors among fellows. Peter, go ahead.
Well, thank you very much for that very kind introduction, Dr. Sayed. And to everybody, good evening. It is a great pleasure today to be able to speak to you and to join the two distinguished professors in sharing my technique of the pediatric lens surgery. So here are my financial disclosures. They do not pertain to the content of the presentation you're about to hear. So briefly, this is what we will go over. I'll go over timing of surgery, a brief discussion about whether we're going to operate on both eyes on the same day, and then focus the rest of the talk on the surgical technique. So as far as timing of the surgery, we all know it's a balancing act. On one hand, we want to maximize visual development by restoring the visual axis. On the other, we want to minimize complications. That's including anesthetic-related issues, and of course, the most dreaded complication, which is secondary glaucoma. And I make my choice based on the findings of Eileen Birch's two excellent studies, albeit they're quite old. They're from about 20 years ago, that show that in both unilateral and bilateral cases, if you do the surgery up to about 6 weeks of age, there's really no change in the visual outcome. So doing it 2 weeks versus doing it 6 weeks, the visual outcome doesn't seem to change. However, after 6 weeks, then we start to lose potential visual outcome. How about the glaucoma risk? Vishwanath in 2004 did a retrospective series and noted that cataract surgery too early, before 4 weeks of age, greatly increased the risk of secondary glaucoma. And this was verified by the infant aphakia treatment study in their 5-year outcome and complications paper, where young age was independently associated with glaucoma later on. So as far as when do I do the surgery? If the child was diagnosed as an infant, I do the surgery between 4 to 6 weeks of age. If they're diagnosed after the 6-week window, before 14 weeks of age, I do it very urgently. And after 14 weeks of age, I do it as soon as feasible. Both eyes at the same session, again, back to the balancing act. On one hand, we want to limit anesthetic exposure risk, all the while minimizing endophthalmitis risk. A theoretical risk, of course, is if you have a contaminated water source or contaminated air particles, you can end up having endophthalmitis in both eyes. As far as anesthetic exposure risk, my colleague, Kara Cavuto, and I, every couple of years, we will go back and look at this issue, and we submit our findings to the current opinions paper. Here's the most recent one, where we looked at the neurodevelopmental effect. And of the 3 large studies in America, the GAS, the PANDA, and the MASK, we have the following conclusion. Number 1, if the exposure is less than 120 minutes, at the age of 5, the children don't seem to have any significant cognitive effect. Similarly, from the PANDA study, if there's only 1 single exposure prior to the age of 3, there's no measurable cognitive changes. However, the MASK study showed that multiple exposures can be associated with a modest executive dysfunction. And how about endophthalmitis risk? A large series in adults, these are sutureless phaco emulsification cases, showed that immediate sequential bilateral cataract surgery is the same, or actually had lower risk compared to unilateral surgery in terms of endophthalmitis. So in my practice, if the child presents under the age of 3 years with significant cataract in both eyes, I would do immediate sequential bilateral cataract surgery, unless there's a reason to make an exception. So with that out of the way, let's talk surgical technique. We all know this, infant eyes do not behave like adult eyes. It's actually a different organ altogether surgically. It collapses easily, the wounds don't appose well, exuberant inflammatory response, there's a very annoyingly elastic capsule, and the posterior capsule will pacify. So from most of us who trained to do surgery on adults and had to adapt our technique into children, we keep our incisions small, we suture all incisions, we use lots of steroid, we use a modified capsulotomy technique, and we always try to open the posterior capsule. This is one of the first videos that demonstrates my capsulotomy technique. I'm in the habit of doing a vitrectorexis. I used to do a manual CCC, but as it turns out that my instrument is 20 gauge, and then my institute switched over to 23 gauge vitrector packs, so that instrument no longer fit. And so I acquired this technique, and after some practice in my hands, it performs very similarly to a manual CCC. Once we forward the video a little bit, you will see that the rexis could be quite round, the edges are quite smooth, and there's actually a fairly small risk of just tearing out compared to CCC. As you can see from the red reflex here, we have a fairly round rexis. And so for me, this obviates having to get yet another piece of instrument. I can go through a 23 gauge incision without enlarging it. So this is my preferred technique. IOL or no IOL? Well, this is controversial. In America, we always mention that intraocular lens usage is not approved by the Food Drug Administration. And because lawsuits happen a lot here, that's an important thing to mention to the parents. However, I always emphasize that it is the standard of care, at least for children over 2 years of age, by a Delphi consensus panel. Typically, we will want to underpower the IOL implant based on a normogram. However, if a child has unilateral cataract and dense amblyopia, I will actually aim plano because that facilitates amblyopia therapy. And the IOL usage under the age of 2 is far more controversial. So we can talk about this topic without briefly talk about the infant aphakia treatment study. It's the prospective multi-center randomized clinical trial that compared primary IOL and aphakia with contact lens in children with unilateral cataract that were operated upon prior to the age of 7 months. And here are the inclusion and exclusion criteria. It's important to point out that they excluded eyes that are grossly abnormal in terms of corneal diameter, that already have pre-existing ocular hypertension or severe persistent fetal vasculature. Without going into further details, at 5 years, they realized that between the two groups, there's no significant difference in the visual outcome. However, the primary IOL group seemed to have higher risk of requiring more surgery, mostly to clear an opacified visual axis. So in my practice, under the age of 1, I will leave the child aphakic unless special circumstances. In terms of IOL calculation, this is very much flavor of the month. I routinely look at the literature and see which one is the most recent large retrospective study looking at predictive power. And currently, my favorite formula is SRKT, because that gives me the closest postoperative refraction. Now, in terms of posterior capsule, we know that opacification rate is approaching 100% in children, and amblyopia therapy is our main goal, so the posterior capsule has to go. I routinely do this until the child is 8 or 9 years of age, and one good gauge whether they can sit for a slit lamp examination. If they cannot sit for a slit lamp examination, we won't be able to YAG it, and we have to do a posterior capsulotomy. So in summary, before the age of 3 years, I do bilateral immediate sequential surgery. Under the age of 1, I leave them aphakic. Over the age of 2, I will offer an IOL. Between the age of 1 and 2, I will implant an IOL if they have unilateral cataract only, their eyes are mostly normal, and if contact lens or glasses are inaccessible to the family. As mentioned, I prefer the SRKT formula, and I do a posterior vitrectorexis. So here I have 2 videos that show beginning to end how I perform cataract surgery. The first one, I'm going to leave aphakic, and the second one, I'm putting in an IOL. So I routinely use a silk suture to prevent the eye from supraducting under anesthesia. I prefer to open up the conjunctiva, even though most of my incisions are corneal, as you can see here. Here's the anterior chamber maintainer. And here is my 23 gauge instrument, which I'm creating a 23 gauge wound. And I introduce the vitrector. I'm looking for a very tight fit to prevent the anterior chamber from collapsing. And as I demonstrated in the earlier video, here I'm going to perform a vitrectorexis. I use a very low cut rate, about 150, and fairly high vacuum at this point, about 300. And basically, I am creating a series of openings and joining them together. I find it easiest to do 2 curvatures and join the 2 curvatures together into a circle. And this, of course, is followed by piecemeal removal of the cortex and the nucleus, which I sped up over here. And you will see the reassuring red reflex showing up in a little bit. And finally, because we're not putting in an IOL, I simply turn up the cut rate to about 600 to 1,000. I turn the cutter posteriorly, and I open up the posterior capsule and disrupt the anterior hyaloid. I like to constrict the pupil with Myostat. And as I mentioned, I suture all wounds with the resorbable suture, usually 10 Vicro. And the last thing I like to do is I close the conjunctiva over my clear corneal wounds, and then by injecting a medication in the form of a bleb, it forms a low pressure patch. And here's the last slide and video. This is a child with radiation-induced cataract. I will be putting in an IOL. And through that, I do a scleral tunnel right here. And the rest of the technique is very similar to the previous video. I'm doing my Refractorhexis right here, and then removing the cortex and the nucleus. And I realized that radiation-induced cataract seems to have particularly sticky cortex. So these cases usually take a little bit longer than usual, although they are not particularly more difficult compared to routine childhood cataract surgery. And here I'm going to enter the scleral tunnel with the keratome. We're going to inject a one-piece IOL in the bag, center it, and suture all the wounds, remove the helon. And because the IOL is in place to remove the posterior capsule, I like to go through the pars plana. And usually try to make an opening that is just under the size of the optic. The key here is prior to removing the retractor, we have to shut down the infusion so that the pressure in the anterior chamber does not push the IOL into the vitreous cavity. And that's why this particular child looked like 2 months after with best corrected visual acuity of 20/25. And that's the end of my part. Thank you very much.
Thank you so much, Peter. This is a great presentation, and it reminded me of my days with you as a fellow. I have a couple questions for you. So why do you use an AC maintainer? Why not just inject viscoelastic, for example?
Yeah, that's a good question. We know that AC collapse during surgery perhaps precipitates angle closure later on. So I really like to have a very exquisite control of the intraocular pressure and the AC depth. And in my hands, the anterior chamber maintainer does just that. I can turn it on, I can turn it off. The only downside is one more incision that I have to close, but it offers a lot more advantages than disadvantages. So I'm in the habit of using it.
Okay. And the other thing is, like, why not a clear cornea incision, like, you know, where you place the IOL? Why do you have to do a peritomy and, you know, make a scleral tunnel?
Yeah. A lot of the times when we do surgery on young children, even with aggressive stromal hydration, the wounds do not EAPOS well. And even when you suture, sometimes if you tie the knots a little bit too tight, there's a tendency for the AC to shallow or to flatten. And so in order to be absolutely sure that I'm not going to lose the anterior chamber depth in the postoperative period, I do a peritomy in order to cover these wounds. The other precaution was that a lot of my patients, especially young children, are incredibly difficult to examine immediately after surgery. So doing it with this technique, even if I cannot examine them, I know with fair certainty that the eye is probably doing okay without a flat chamber.
Thank you so much, Peter. Dr. Ayman, unmute.
Yeah, thank you. I think it's time to, it's very interesting video. I'm really, I have also some questions, but maybe we postpone at the end of the 3 presentations. The next presentation will be from Dr. Nihal. I'm asking Dr. Nihal, please, to start sharing your presentation. And I am really honored to introduce Professor Dr. Nihal Elshakankiry. I think she's already well known. She is a professor of pediatric ophthalmology at Alexandria University. And she's actually a role model for me and for many people. She has been dedicated for pediatric cataract surgery for more than 20 years. exclusively doing pediatric cataract surgery. So that's really, and she's really doing a huge number of patients on a weekly basis. So that's real experience. And also she has a unique experience in her center of a pediatric ophthalmology unit in Alexandria University. All state of the art of everything, and treating many children from everywhere in Egypt and from elsewhere. So I'm really honored to present Professor Nihal Elshakankiry. Dr. Nihal, please start your presentation.
Bismillah ar-Rahman ar-Rahim. It's a pleasure and honor for me to participate in this webinar speaking about congenital cataract. And as you know, congenital cataract surgery is still a debatable issue, because are you going to go for the cataract surgery through anterior approach or through the posterior approach? And whether you're going to fit the baby after surgery with aphakic spectacles, or you're going to go for contact lenses, and which type of spectacles you're going to choose, and the type of even the glasses and the frames. So it still is a debatable issue. So concerning my talk, since the time is so limited, I'm going to speak only about the surgical techniques and giving some tips in the surgery in order to perform a safe and sound surgery through the anterior approach, which I prefer the most. Concerning the cataract surgery with IOL implantation. In infants and children where we're going to implant intraocular lenses, I start by the side port first, and then inject the viscoelastic, and then go with the other side port. And then lastly, I go with the main wound. Why? In order, if you start by the main wound, sudden collapse of the anterior chamber through this corneal wound will cause a sort of constriction of the pupil, and you're going to touch excessively the iris, which may increase the risk of inflammation later on. And then concerning the anterior capsulorhexis, in order to avoid this terrible picture of capsular phimosis, I use trypan blue stain only in total cataract where I cannot see the red reflex. And in these cases, because I'm going to implant intraocular lens, I aim for a 5mm anterior rhexis, exactly 5. This is before stain, here after stain. And I use the rhexis, I use actually is a 25 gauge rhexis or 23 gauge. And then I perform the rhexis, and it is exactly 5. Why 5? In order, this is another slide showing how to go for the rhexis. By the cystotome, we make a small paracentral tear, and then this is a 23 gauge rhexis. We go with the rhexis. You pull here tangential, and then if you feel that you're gonna go to the periphery, pull towards the center. Again, pull towards the center until you achieve exactly 5mm rhexis. And if we have a lamellar opacity, this lamellar opacity is usually 5mm in diameter. So it's a beautiful landmark for our anterior capsulorhexis. We make the tear here, and then we start the rhexis. See, we follow the edge of the lamellar opacity. We follow the edge here at the edge of the lamellar opacity, frequent regrasping until you obtain a beautiful, exactly 5mm anterior rhexis. And if the lamellar opacity is totally opacified, we can go with the rhexis just outside the lamellar opacity against the red reflex. Why? Why this 5mm? Exactly 5. In order, when we implant the IOL inside the capsular bag, the IOL is 6mm, so the anterior rhexis is going to be just inside the optic of the intraocular lens. Supposingly, we did a small rhexis, which is less than 5mm. No, we have to make it exactly 5, and I'm going to tell you why. So after IOL implantation, we can make a tear in the anterior rhexis, a small tear here, and then again with rhexis forceps, we try to enlarge it until it is exactly 5 inside the edge of the intraocular lens. Then comes the hydrodissection. We go with the cannula just underneath the anterior capsule, going towards 6 o'clock position like that, and then we inject. We elevate a little bit the anterior capsule and then inject. We will not see a wave in these cases, but we're going to see here a viscoelastic coming outside the wound, ensuring that you did a perfect hydrodissection. And you will not see any disturbance in the morphology of the cataract. Then hydrodelineation. But take care. In some infants, and it is very common to have a congenital posterior capsule defect, which usually you don't diagnose before surgery. See, this is a huge defect. If you go for hydrodissection and hydrodelineation in these cases, all lens matter are going to fall backward into the posterior segment. In some cases, it may cause secondary glaucoma, but in the majority of the cases, it will be absorbed. But in these cases, you should not go for hydrodissection in hydrodelineation. Look at this to this baby. Can you see here? And here under a microscope, this is the delineation of a posterior capsule defect. See here, after irrigation aspiration, this is the defect. Then comes the irrigation aspiration. You have to go for a very meticulous irrigation aspiration in order to prevent secondary cataract in the future. And a very important step is polishing the back surface of the anterior capsule. Maybe it's not important when you go for a cataract surgery in an adult to do this step, but in infants and children, it is very important. Here, this part of the anterior capsule is polished, but this part is not yet polished. And then you see here remnants of lens epithelial cells on the back surface of the anterior capsule. This is another case. This part is polished and this part is not polished yet. You go for polishing the whole capsular bag until you have a crystal clear capsular bag, here with magnification. Here with more magnification, there is no lens epithelial cells in the back surface of the anterior capsule. Why? In order to have a thin fibrotic anterior capsulorhexis like that, if you want to go for retinal exam in the future, it's going to be easy. But if you don't polish the anterior capsule, fibrosis will occur like this and will prevent good visualization of the retina if you need it in the future. And why exactly 5 millimeter and not 4? Because capsular phimosis may occur, obstructing the visual axis in the future and necessitating secondary surgery to clear the visual axis. Look here, an eye years after surgery. Despite we have a beautiful surgery, anterior and posterior rexes, but we didn't polish the anterior capsule perfectly. Lens epithelial cell did emerge underneath the anterior capsule, and it covered the anterior surface of the lens, while about to obstruct the visual axis. And here, after aspiration, look, the posterior capsulorhexis is beautiful, and lens epithelial cells respect the edge of the posterior rexis. So it's very important to go for polishing of the anterior capsule and to go for exactly 5 millimeter anterior rexis. Posterior rexis, what are the tips to go for a good posterior rexis? Number 1, don't fill the bag with viscoelastic. Inject in order to make the iris, the anterior capsule, and the posterior capsule all in one plane. And then when you bend the cystotome, you just bend half the bevel. Don't bend more. And don't go and dip into the anterior vitreous face. No, go tangential and then go for hooking of the posterior capsule. Tenting, you make a tent. You pull anteriorly, making a sort of a tent in the posterior capsule. And then tearing. You make a sort of a triangular tear. Once you have a triangular tear in the posterior capsule and not a rounded one, it means that you didn't open the anterior vitreous face. And if it is rounded, it means that you did penetrate the vitreous face and the vitreous did emerge. And then through this triangular tear in the posterior capsule, we go and inject viscoelastic into the burger space. We don't go into the tear and inject. Otherwise, we're going to have this terrible picture of viscoelastic inside the vitreous. And this will make the posterior rexis difficult. So what to do? We just, from the edge of the tear, we inject. We're going to see a sort of a rounded or a circular halo that will increase when we inject. It means that we are in the right space, in the burger space, and we didn't open the anterior vitreous space. If we do so, it's going to be very easy to go for the posterior rexis. Again here, hooking tenting, and then tearing into a triangular tear. And then through this triangular tear, introduce the viscoelastic. I don't know whether you see it or not, the circular halo of the viscoelastic into the burger space. Can you see this? This is a circular halo in the burger space. And then if you do so, the posterior capsulorhexis is going to be very simple and very easy. And in these cases, we go for exactly 4 millimeter posterior rhexis. Anterior vitrectomy. We don't want to see this terrible picture of vitreous in the anterior chamber. So go first with dry vitrectomy and then introduce the irrigation afterwards. In these cases, I never use intracameral steroids, because if vitreous prolapse, I can see it. Can you see here? There is a sort of a kinking of the posterior rhexis, meaning that there is a sort of a vitreous strand coming here to the wound. So again, we go for dry vitrectomy. And then see, this is not enough, that it's still kinking of the posterior rhexis. Again, go for dry vitrectomy until you have a perfectly circular posterior capsulorhexis. What is the extent of anterior vitrectomy? We should remove part of the anterior vitreous perfectly. We go beyond the edge of the posterior rhexis and dip at 12 o'clock to remove part of the anterior vitreous face, 1/3 of the anterior vitreous face. Why? Because vitrectomy is very important. Lens epithelial cells after years will grow over remnants of the anterior face and sometimes occluding the visual axis, even in the presence of posterior capsulorhexis. But when we go for a good vitrectomy, we're going to have clear visual axis along years, even if the size of the posterior rhexis is small. But with a good vitrectomy, we're going to have clear visual axis. IOL implantation. We fill the capsular bag, and I use the multi-piece or single-piece hydrophobic acrylic lenses. We inject the IOL inside the capsular bag. This IOL unfolds easily, and then we push it between the anterior and posterior rhexis, or the multi-piece intraocular lens implanted inside the capsular bag, and then we rotate the IOL to be inserted between the anterior and posterior rhexis, or another simple technique. Introduction of the IOL, and it is very important to ensure that the lower haptic just underneath the anterior capsule. And then push the haptic optic junction disc inside the capsular bag, and then push the optic inside the bag. And then the upper haptic, just take the distance halfway between the haptic optic junction and the edge of the haptic. By a Y-shaped spatula, you push it until the haptic optic junction here inside the capsular bag, leave it, it's gonna be easily inserted inside the bag between the anterior and posterior rhexis. We can use the multi-piece or the single-piece intraocular lens between the two rhexis. And finally, we make wound closure. Concerning, this is few weeks after surgery, few months after surgery, single-piece intraocular lenses. Can you see here, few months, beautiful situated intraocular lens between the anterior and posterior rhexis. Few years after surgery, can you see lens epithelial cells respecting the posterior rhexis? Here, lens epithelial cells, but with clear visual axis. 2 years after surgery, 5 years after surgery, 10 years after surgery, there's extensive pearls, but still we have clear visual axis. Concerning the multi-piece intraocular lenses, few weeks after surgery, years after surgery, 5 years after surgery, extensive pearls, but with clear visual axis, and 10 years of multi-piece intraocular lens inside the capsular bag. There is fibrosis, there is pearls, but we have beautiful clear visual axis. This is concerning the tips when we have the cataract surgery with IOL implantation. Concerning the cataract surgery without IOL implantation in infants with bilateral congenital cataract, in whom we're going to go for the cataract surgery and we're going to fit these babies with aphakic spectacles. I use corneal ones without opening the conjunctiva, using an MVR knife 20 gauge and not 19. That means 0.9 millimeters. And then I use trypan blue stain in order to facilitate the performance of anterior capsulorhexis. In these cases, I don't perform 5 millimeter rhexis. It should be exactly 6 millimeters, not less and not more. And we're gonna see why. Here, but when I have a good red reflex, I perform a paracentral incision, and again, with a 25 gauge rhexis, I perform the 6 millimeter anterior rhexis. And you have to go for frequent regrasping and pulling towards the center to have exactly 6 millimeter anterior rhexis. And then the usual hydrodissection, hydrodelineation, irrigation, aspiration. And then we go for the posterior rhexis in the conventional way, hooking, tenting, tearing, triangular tear, injection into Berger space, and then holding the rhexis. And these are the infants. I don't go for the pars plicara. I use again the 25 gauge rhexis, and I perform the posterior rhexis. In these cases, I perform the rhexis not 4 millimeter, but also 6 millimeter, like the anterior rhexis. And then we go for a very good anterior vitrectomy and finally closure of the wound. Why? Why do you go for the 6 and 6 millimeter anterior and posterior rhexis? Because if we go to the conventional anterior 5 and posterior 4, what's going to happen? The fibrous ring, the capsular bag will shrink. And by time we're going to have a capsular phimosis obstructing the visual axis, necessitating secondary surgery to clear the visual axis. This is a capsular phimosis. We have to go again with the scissors to cut the capsular phimosis and clear the visual axis. So we're going to have to go for secondary surgery. And if we go for a larger rhexis, larger than 6 millimeters, what's going to happen? Larger rhexis than 6 millimeter, the ring will retract. So smaller than 6, contraction. Larger than 6, retraction. What's going to happen? At time of secondary IOL implantation, see, this is the capsular support. It is retracted. Here, it is retracted. It will be difficult to implant the secondary IOL. Look here. This is a time of secondary IOL implantation. The capsular support did retract, and it was quite difficult to implant the IOL inside the capsular bag and rotate it in the sulcus. Sorry, to rotate it in the sulcus. Very important tip concerning the anterior vitrectomy. It has to be remove anterior 1/3 part of the vitreous. Why? Because by time lens epithelial cells will grow over remnants of anterior vitreous space, even if you have a beautiful anterior and posterior rhexis, but without good anterior vitrectomy, lens epithelial cells may obstruct the visual axis. So finally, for infants without IOL implantation, 6 millimeter anterior rhexis, 6 millimeter posterior rhexis, good anterior vitrectomy. And this capsular ring, by time it will contract, it will be a beautiful capsular support for secondary IOL implantation in the future. The IOL will be easily implanted years after surgery. And even in some cases, we can perform implantation in the sulcus and perform optic capture technique. And finally, we fit the babies with aphakic spectacles, and this is our preferred frames. And the preferred lenses is lenticular lenses, ultra thin, high definition lenses, and they are beautifully tolerated even by infants. And finally, to conclude, these were only some surgical tips in pediatric cataract surgery to perform a safe and sound surgery without complication in these adorable young infants. And thank you very much for your kind attention.
Thank you very much, Dr. Nihal. That's an amazing presentation. Very, very clear presentation, very clear slides. That's the usual for Dr. Nihal. That's very amazing. I have a couple of questions for you, if you don't mind. You mentioned the size of the capsulorhexis, the 4 and 6 and 5. How easy it is to reopen the bag again and insert the intraocular lens. You're talking about both will be the same size for aphakic patients. You think it's easy to reopen the bag and then insert it again?
Really sorry, I meant I implanted, of course, inside the sulcus. When you go for a 6 millimeter is a primary surgery, 6 millimeter anterior and 6 millimeter posterior. They will fuse. It's going to be a sort of a capsular ring, and you're going to implant the IOL in the future in the sulcus. And if
the video,
you can go for optic capture technique.
Okay, and you don't try to already open the bag again.
No.
Okay, but one more question, please. You mentioned that you sometimes put single piece, sometimes 3-piece in the bag.
Yes.
When do you prefer this one? When do you prefer that?
Well, both can be implanted, but if the cataract is straightforward, like these cases, and easy to perform, like for example, the lamellar cataract or something like that, I prefer to use the single piece intraocular lens because the wound is smaller and you're going to inject the IOL inside the capsular bag. It's going to be easy to be injectable within the bag. Concerning the multi-piece actually I use it in more complicated cases when you have a posterior capsular plate, when you have a posterior lenticanus, when you have different pathologies other than straightforward congenital cataract surgery, because I usually enlarge the wound a little bit in order to facilitate the introduction of the intraocular lens. But both work perfectly. Whatever option you choose, both are perfect.
And for the anterior vitrectomy, do you have any recommendations for the settings of the anterior vitrectomy? You mentioned that we have to take over the anterior 1/3, but I mean the settings for the vitrectomy, cutting vacuum. Do you have any specific preference for this?
Yeah, I use a vacuum. I use actually the Goiter machine. So my parameters are, I use a vacuum of 150. I use a cutting rate ranging from, I don't use high rates, I don't need it. I like the slow rate, so I use 650 cutting rate. And the height of the bottle is very low because I don't want severe hydration or massive hydration in order to prevent overhydration of the vitreous. And as you see, I introduce the irrigation and get it out. I introduce it and get it out. It's not inside the capsular bag from the start in order to prevent overhydration of the vitreous.
Yeah, that's interesting. Well, we still have many questions for you and also questions from the audience, but we'll postpone until the end of this section of the basic part. Okay, so Dr. Dina, you can take over and
yeah, now we move to the next talk. And I'm really privileged to introduce a true leading figure in pediatric ophthalmology, my mentor, Dr. Hala Elhilali, Professor of Ophthalmology, Cairo University, and Vice President of the EAPOS. Dr. Hala is actually known for her furry wand that transforms every place she has been in charge of. I know that the years she headed Abu Rish, Cairo University Pediatric Ophthalmology units are the closest to her heart. She just made us all come together, develop and expand the services provided. She dedicated a tremendous amount of time and effort in teaching doctors and fellows and supporting research. Actually, it would be impossible to count all the ways that she's helped and taught us all, but she truly inspired a whole generation by her humbleness, hard work, and utmost support. We're very glad to have you with us, Dr. Hel. You can start sharing your screen and unmute.
Please unmute, Dr. Hala, please unmute your voice.
Okay, is that better?
Yes.
Thank you. So thank you, Dina. It was very, it's an overwhelming introduction for me and emotional too. So without further ado, I will, and it's really exaggerated, I will go on with my presentation. So I'm presenting my preferred surgical techniques. There are a lot of points that I have shared similar views to Peter and Nihal on many things, but I also have some comments that I will keep till the end. So it's not it's not moving forward. Okay, so if I'm performing cataract surgery without IOL implantation, my preferred technique is to do a pars-plate catalensectomy. I find that minimizes surgical trauma to the cornea and the iris, which reduces the post-operative inflammatory response. It eliminates the need for corneal incisions that may end up in corneal scars that you will see in the photo on the right. or the possibility of having iris strands adherent to the back of the corneal incisions. I always prefer to remove vitreous through the pars plicata. That ensures that I don't have any vitreous left in the end at the anterior chamber, or any strands of vitreous attached to to the back of the incisions. This is a picture through a gonio lens where you can see the iris adherent to the back of the wound and angle closure around stenting of the iris, and also angle closure around that area. This is a table that we have hanging outside our OR, and it's the relationship between the sclerotomy sites and the age of the patient. So when patients are less than 6 months old, the sclerotomy site is actually 1.5 millimeters from the limbus. But when they're 3, it moves back to 3 millimeters, and this is a guideline to where you put your sclerotomies. This is the basic surgical technique that I use for pars plicatal lensectomy. Of course, we're measuring the site of the sclerotomy with calipers. Light cautery is applied to the sclerotomy sites. The sclerotomy itself is performed with an MVR blade that also carries the incision into the equator of the lens. And we perform 2 such sclerotomies, one at 2 o'clock and the other at 10 o'clock, as you see here, again, going through the equator of the lens. This is followed by the irrigation going into through the equator of the lens and into the lens, followed by the pars or the vitreous cutter. This is a 23G cutter, and at that point, what I'm using is just aspiration only, very little cutting, and I keep the port of the vitreous cutter on the side to reduce the possibility of prematurely opening the anterior or posterior capsules. I then turn the port of the vitreous cutter back and activate cutting in order to start removing the central part of the posterior capsule. This is the port. Now it's under the posterior capsule, and I'm enlarging the size of the posterior capsulectomy, the central size. And I agree with Dr. Nihal that here the size should be about 6 millimeters. And then the final step is to remove the anterior capsule, and I prefer to keep that till the very end because that reduces turbulence in the anterior chamber and trauma to the iris and the cornea. And after reaching an adequate size, an anterior vitrectomy, again, that involves 1/3 of the vitreous, is performed, followed by always suturing the sclerotomies. I never leave the sclerotomies without suturing. So this is the appearance of the rim, both the anterior and posterior rim that adhere together, and they're starting fibrosis at around the 6 o'clock position. That's 1 month after surgery. This is a year after surgery, another patient coming back for secondary IOL implantation, and you see the fibrotic rim of the remnants of the anterior and posterior capsule that are stuck together. Sometimes I need to use a combined anterior and posterior approach, and this in certain situations, such as when I have a poorly dilatable pupil, oftentimes that happens, and I create 2 corneal incisions that are almost diametrically opposite. I use 2 Sinskey hooks or push-pull instruments, and I introduce them, and I pull the edge of the pupil in a diametrically opposite directions, in order to create small tears at the sphincter pupillae, dilating the pupil to an adequate size. I then go back and I use my old technique of pars plicata lensectomy, again, because I prefer always to remove vitreous through that approach. Combined approaches also, I use that for what I call cataract plus, when there are other anomalies like remnants of pupillary membrane here. I use 23G scissors to sever the attachment to the anterior capsule. And because there was a fibrotic plaque on the anterior capsule, I also chose to do an anterior rexus using Capsulorhexis forceps. These are micro forceps. And I carry my rexus all the way up to the fibrotic plaque, but then I stop, and then I use scissors to cut through the plaque, because that plaque will not tear easily. And this is followed by completion of the rexus. Again, you can continue your surgery through an anterior approach here, but I actually prefer to go back and finish the surgery through the pars plicata. This is my surgery for when I'm performing cataract with IOL implantation. in a child who's younger than 4 years, 4 years or younger. In this case, I remove the central part of the posterior capsule and the anterior vitreous. I use an anterior approach first to perform the rhexis, and Nihal showed very elegantly how that is performed using the Capsulorhexis forceps, and actually we kind of pull on the anterior capsule centrally in order to finish the rhexis. This is followed by hydrodissection. In order to manipulate the cortex into the anterior chamber or maneuver it into the anterior chamber, I prefer phacoaspiration because it speeds up the process of removing the lens cortex. The fibrotic plaque on the anterior lens capsule is then removed from the anterior chamber, and by manual irrigation aspiration is used to remove the rest of the cortex and scrape the epithelium off the back of the anterior capsule, which is again very important. This is the introduction of the IOL. It's a single piece, acrylic hydrophobic IOL, and it's introduced into the bag. And when you put the IOL in before removing or doing the posterior rhexis, it ensures that both the optic and haptics are secured in the bag and that you really have them well positioned. This is followed by a sclerotomy at the pars plana, followed by removal of the central part of the posterior capsule with a vitreous cutter. Pass through the pars plana, but the irrigation is still in the anterior chamber. Now, presence of the IOL flattens the posterior capsule and stretches it, and that makes removal of the posterior capsule easier with the vitreous cutter. And it also allows me to size it, size the posterior capsule well. This is why I like the pars plicatum approach to removal of the posterior capsule and anterior vitreous. It ensures that the IOL is in the capsular bag. It centers the posterior capsulectomy behind the IOL optic. It allows better sizing of the posterior capsulectomy. I see the edge of the optic, and I keep my posterior rhexis inside that. It ensures absence of vitreous strands in the anterior chamber or the wound. Nihal has really demonstrated very well how important to diligently scrape the epithelium off the back of the anterior capsule to prevent epithelial reproliferation and visual axis obscuration. Oftentimes, we need to improve our visualization of the anterior capsule, and this is done using trypan staining under air, followed by removal of the air, replacing it with viscoelastic, and performing the rhexis with the stained capsule to improve visualization. This is the regular Capsulorhexis. Another tip here, because I found that there was a positive pressure within the lens, often it's prudent here to keep the anterior Capsulorhexis small and controlled, because at the end of surgery, what you can do is always enlarge that rhexis to the size that the desirable size. It's easy, again, when you have the IOL in the bag and the anterior capsule is flattened, that you are able to optimize the size of your rhexis. In cases where the child is more than 5 years old, this is what I do. It's a posterior rhexis, small incision, viscoelastic injected behind the rhexis. You can see the wave pushing the vitreous backwards, enlarging the capsular opening using, again, Capsulorhexis forceps to tear the posterior capsule in pretty much the same way that we do the anterior rhexis, with ripping and always pulling towards the center. And once the posterior Capsulorhexis is completed, my vitreous is back and I haven't touched it. I implant the IOL within the capsular bag, and you can see here that the well delineated edge of the anterior and posterior rhexis. Thank you very much. These are my preferred techniques.
So I have a couple of questions, Dr. Hala.
Sure.
So at what age do you stop doing anterior vitrectomy and just do the posterior Capsulorhexis?
Okay, I continue to do posterior rhexis up to the age of 6 or 7, because at that age the child can sit at the YAG machine. But starting from the age of 4, I don't do an anterior vitrectomy. I think the posterior rexis is enough. I haven't seen opacification of the anterior vitreous face. And in the rare occasion that would happen again, the child would be old enough to sit at the YAG machine. So I go for not disturbing the anterior vitreous face in that age.
And are there any cases where you prefer to leave the posterior capsule intact?
Yes, absolutely. When I'm performing cataract surgery for patients with congenital glaucoma, who have undergone surgery for congenital glaucoma, and they develop cataract oftentimes, I prefer to leave the posterior capsule intact. It's essential actually in these cases to put the IOL in the bag, because the sulcus is too large and will never be stable. The IOL will never be stable. But once I have the IOL in the bag, and again, you have to do a meticulous cortical cleanup and scraping of the anterior capsule, but I prefer to leave the posterior capsule intact, because these patients have a very liquidy vitreous. It's not vitreous anymore. It's just it's like water, and they have very low scleral rigidity, and opening the anterior capsule may lead to a collapse of the eye. So I prefer to leave the posterior capsule.
Okay. And one last question before starting the discussion: do you ever leave your sclerotomies sutureless?
Absolutely not. In children, you have very low scleral rigidity. Endophthalmitis was reported with leaving these sclerotomies sutureless, so I always suture all my incisions tightly.
Okay, thank you so much for this excellent talk. And now we can have a 10 minutes discussion. I see we have many questions from the audience. Dr. Muhammad, can you just start asking some questions of them? You're still on mute.
I'm still trying to absorb all the information that we got from these 3 beautiful presentations. Overwhelming.
Indeed.
I'm going to start with this question to Dr. Chang from Dr. Amr Kamshushi from Alexandria University. You talked about the cognitive issues that may arise from repeated anesthesia exposures. But you know that children with cataracts and glaucoma and other anterior segment diseases would require frequent EUAs. How frequent would you do the EUAs, and what is a reasonable schedule, knowing that there is a trade-off?
Thank you for the question. Before I answer, I just want to say that the surgeries for absolutely virtual OSIC from Dr. Hala and Dr. Nihal, and apparently children in Egypt are made of tougher stuff than American children, because I have a hard time getting anybody younger than 10 to sit at a YAG machine. So that explains a lot of the practice pattern differences. Now, regarding the neurodevelopmental effect of anesthesia, I think congenital cataract and congenital glaucoma should be discussed as 2 separate entities. Here's why. Most of the time in fairly simple congenital cataract, they don't require another exam under anesthesia until after the age of 3 and beyond. The average time to developing glaucoma is actually about 5 years after, based on 1 series. So for that particular case, I want to get the surgery over with, keep it under 2 hours, do both eyes at the same time, keep it just 1 anesthetic episode to maximize any possible neurodevelopmental advantages. Now, with congenital glaucoma, we know we're committing the child to having multiple episodes. That part is not in dispute. The neurodevelopmental risks from anesthesia has been very well demonstrated in animal models. But as far as in older children, that's usually measured by very fine-tuned instruments. This is not something as obvious as school grade or reading ability, at what age are they able to read, etc. So in those cases, I would tell the parents, yes, there's a theoretical risk of repeated exposure to anesthesia, but the risk of blindness is real. So you're weighing something theoretical on one side versus a very real risk on the other side. In those cases, we will take the real risk more seriously and still expose those children to multiple anesthetic episodes. Now, as far as how often, that's a little bit beyond the scope of what we're discussing. And it has to do with, number one, whether their pressure is controlled or not. Number two, are they on medication or not? And number three, do they have a tube shunt implant or not? If their pressure is controlled on no medication and they don't have an implant to become exposed, I usually do EUA no more frequently than every 6 to 8 months, and much more frequent if they're higher risks.
Okay, there's a question to Dr. Nihal. What do you do in unilateral cases if they present between 6 and 12 months? Like at this age, do you consider primary implantation, or you just do the lensectomy and defer the secondary implantation later on?
If the baby is 6 to 12 months, I would go for primary cataract surgery and IOL implantation. But below the age of 6 months, I go for the cataract surgery only, and I don't have the option of contact lens. So I fit the baby with aphakic spectacles and the fellow eye ground glass, and I occlude the fellow eye and make him wear the spectacles half waking hours until the age of 6 months, and then I go for secondary IOL implantation. Why? I don't implant below 6 months because, you know, the curvature of the cornea changes massively in the first 6 months of age. So I have to skip this, and then I implant at the age of 6 months.
Okay. And a question to Dr. Hala. When one of the audiences is asking, when I do pars plicatum anterior vitrectomy after IOL implantation while putting the infusion in the anterior chamber gets very deep and the posterior capsulotomy sometimes gets uncontrolled. How do you adjust for that?
Yeah, well, that's the part of the surgery where you have to lower your bottle, because you don't want the pressure anterior to the lens to be higher than the pressure behind the lens. So you have to keep that bottle at a low point. The other thing is if you have an adequate size of the anterior rhexis, and the fluid usually finds its way behind the posterior capsule as well. So that also helps to maintain, but you have to adjust the size and do that part of the surgery relatively quickly so that you can control it and control the but I actually find that the presence of the IOL stretches the capsule for me, and it makes it easier for me to do the posterior rhexis through that approach. And I don't know whether Peter has the same experience, or do you want to add anything to this?
I completely agree with you. So right before I start my posterior vitrectorhexis, I would lower the infusion to about usually between 12 and 15. I will go up a little bit higher if I see the AC is dangerously shallow, but no higher than that. I will do the rest of the cataract surgery with the pressure about 30 to 35, but definitely lower it to about 12 to 15. And I make sure I close the infusion before I take out my instrument, because that way you do not have unopposed pressure, as you mentioned, from the anterior chamber pushing on the IOL and risk pushing it into the vitreous cavity.
I would just like to mention something about my parameters during the surgery. So while I'm doing the lensectomy, removing the cortex, it's mainly aspiration that I'm using, and I use about a vacuum of 500. And when I point the port of the vitrector backwards to do the cutting of the posterior capsule, I activate cutting aspiration mode, where the cutting is 500 and the aspiration is also 500. But when I'm doing removing the vitreous, I lower my aspiration and I increase my cutting, because you don't want to be pulling on the vitreous. You want to cut it and then pull it. So these are my parameters.
Okay. And
So
Dr.
I have
Nihal?
a question actually to Dr. Nihal. So there is a question from one of the audience about capturing the haptic behind the posterior capsulorhexis. And I've seen videos of Dr. Ayman Elghonemy, for example, who wouldn't do anterior vitrectomy because he would say that the captured haptic behind the posterior rexes would create a tamponade effect and prevent, like, any vitreous from like kind of creeping on the like posterior capsule or behind the IOL. What do you think of that?
I really don't recommend it. I did follow up my cases for more than 20 years now. I'm telling you, number one, if you don't remove the vitreous, and I showed you photos like that, you have a beautiful anterior and posterior large rexes, and you have inadequate vitrectomy. Lens epithelial cells did grow over these remnants of anterior vitreous face. So you should go for vitrectomy. I don't recommend optic capture in the primary cataract surgery. If you have a beautiful surgery, anterior and posterior rexes, why to capture? If you want to go for IOL exchange in the future, it's going to be very difficult. And we go frequently for IOL exchange for a myopic shift. So I don't recommend it as a primary procedure. But actually, this optic capture technique has many advantages, but not of them as a primary cataract surgery. If you lose the posterior capsule, you can do sulcus implantation and then optic capture in the anterior capsule. If you don't have anterior capsule for cases in a traumatic cataract, you can go for a posterior rexes and make optic capture. If you have a membranous cataract, so in secondary IOL implantation, you can capture the IOL in the capsular ring. But to do it as a primary procedure for straightforward cataract surgery, I don't recommend. And vitrectomy, in my opinion, is a crucial and important step.
Okay, so now we can go to our next poll question before completing the discussion. So can we have the second poll question here? So what's the earliest age you consider implanting an IOL in unilateral cases? Below 6 months, from 6 to 12 months, above 1 year, or above 2 years?
Please, our audience, please put your opinion and let's hear what you prefer. And for the speakers, if you have anything to add while our audience are participating.
Yes, so Dr. Chang, do we have actually a common consensus regarding the age and the type of IOL in the pediatric age group?
There is one publication where I think about 12 to 15, mostly North American pediatric cataract surgeons, and they have done a Delphi process. And this was led by Dr. Alex Levin at Wills Eye Hospital in Philadelphia and Dr. Rupa Trivedi at University of South Carolina. And I believe the consensus was that we know when you definitely should think about putting in an IOL that's over the age of 2. And under 2, nobody agreed. So I don't believe there was a consensus as to how young is too young. My mentor in fellowship, Dr. David Morrison, always mentioned that if your hands are tied and you don't believe that visual rehabilitation will occur without putting in an IOL, putting an IOL. It's better than not having any aphakic refraction and the child's eye is going to be blind. And so that's still something that I would share with my trainees, knowing that yes, there's a 60% risk of needing another surgery, but glass can be half full. There's a 40% chance they will do just fine.
Okay, and Dr. Hala, do you want to comment about this?
Well, okay. For unilateral cataract surgery, I would go for an IOL implantation after the age of 6 months. I have like a reasonably good success with contact lenses in about 50% of my cases, but the other 50% I would implant the IOL for visual rehabilitation right after the child is above 6 months. And I've looked at a lot of papers that were published about IOL implantations, and I find that when you really analyze the results, the adverse events and the secondary membranes they mostly form if cataracts or if IOLs are placed in the first 6 months of life, and that the adverse events occur less commonly if the IOL is placed after 6 months. Okay. For bilateral cataract cases, I know that that is not the norm, but I usually implant at the age of 1 year, not 2. I undercorrect the lenses, so I would leave a residual hypermetropia of +4. Even in bilateral cases, that's what I do. And the reason why I prefer IOLs to thick to glasses or to aphakic spectacles is that I find that it offers an immediate and constant correction. That's one. You don't need the compliance from the parents as much. It also is a much better fit than the thick glasses that sometimes fall off or keep getting off the nose if they don't have a good nasal bridge, or in a lot of craniofacial anomalies, it's even hard to just get any spectacles on. And that's why this is my preferred protocol. I implant. I find also that reduces, for me, or at least I think, the amplitude of nystagmus, and it provides better optics. And I find that I'm getting really good results with visual acuity down the line, like at around 4 and 5. I find my children really do pretty well.
Okay. Dr. Nihal, I want to ask you, is there any place for certain types of intraocular lenses, like aspheric ones, multifocals, or tinted ones for children?
Well, actually, I have no experience in aspheric lenses. I use the conventional multi-piece and single-piece hydrophobic intraocular lenses, and I think they are doing fine. I don't think the multifocal or bifocal lens is going to fit in children, because you have fibrosis in the capsular bag, you have tilting, you have decentration. I don't think it's wise decision to go for these intraocular lenses in children.
Okay. And Dr. Chang, do you have anything to add to this?
No, similar to Dr. Nihal, I have not had any extensive experiences putting in multifocal or non-monofocal lenses. For 2 reasons. One, some of these children will get retinal detachment, and that's a very real concern. So as we are operating on the cataract, we have to think a few steps ahead that if a retinal detachment were to occur, do I leave a good enough lens and a view for my pediatric retina colleagues to be able to repair the retinal detachment successfully? And I find that a monofocal lens, hydrophobic, offers the best view during such, sometimes inevitable but very difficult events. And the second thought is, I had mentioned in one of my slides, a lot of the parents I deal with will read everything they can find on the internet about whatever it is that's going to the children's body. And for me to even convey to them that the lack of a food drug administration approval does not mean that this is bad for the child, simply means it hasn't been properly studied due to the uncommonness of the disease we're treating. This question is even harder to address with something like premium IOL. And lastly, at least in this economy, in the American economy, any lens other than the monofocal lens is not being paid for by most insurance types. So it's very, very difficult to even start a conversation of having them to pay extra for something of unproven benefit that has never been tested in children. And so for that reason, there's significant barrier to even doing a study of this type here.
Peter, I know you have a simple formula for calculating the refractive target. Do you mind sharing that?
So I carry a cheat sheet, used to be in my pocket as a folded piece of paper, but now it's a photograph of that folded piece of paper on my phone. But basically you take the child's age and subtract it from 7. And that is sort of the roughly the postoperative refraction you want to aim for. So a 3-year-old, you want to aim roughly +4, etc. Now the paper has a little bit more detail than that, but when push comes to shove, I can look at that number, see if it's close to what I think it is, and mentally double check to make sure that I'm selecting a correct lens when I'm about to implant it.
Dr. Nihal, do you undercorrect or aim for emetropia?
It depends on the age. If I am implanting below the age of 2 years, I go for undercorrection, not more than 4 diopters between both eyes. I see the refraction of the fellow eye, and I undercorrect and make a difference not more than 4 diopters. I don't follow the Dahan guidelines that stated that I undergo by 20%, because I'm going to be left with, for example, a plus 10 diopters hyperopia. I cannot fit it in glasses, and the quality of my patients, I cannot fit them with contact lenses. There is no available silicone lenses in Egypt, so I'm going to depend on the hyperopic part, or the hyperopia going to be fitted with spectacles. So I only aim for hyperopia of +4 maximum. Myopic shift will occur. Yes, myopic shift will occur, and it's very easy and simple to go for IOL exchange in the future.
Thank you.
Okay.
I have a couple of questions to Dr. Chang. And there has been a question also in the audience about, you mentioned that what you inject at the end of the surgery. The second question that you mentioned in your presentation, that you inject myotic at the end of the surgery?
Yes, so after the IOL is in place, and before I start to remove the anterior chamber maintainer from the cornea, I inject myostat to constrict the pupil and to prevent either the IOL or vitreous from coming into the anterior chamber. And at the end of the surgery, I inject a bolus of antibiotics and steroid underneath the superior conjunctiva into the tenon. So it forms a bleb and actually further compress the corneal wounds I have made during the surgery.
And don't you think the myotic can cause increased incidence of postoperative uveitis? Don't you think so?
So far, we have not encountered that. Yeah.
Okay. Okay. Discussion is very rich and very interesting, actually. But I'm sorry, we have to shift to the next part of our webinar about some interesting complex cases. So the first presentation will be Dr. Chang. So if you don't mind, please share your presentation now. Dr. Chang will speak about a very interesting topic about the pediatric lens surgery in treatment of angle closure glaucoma. So please, Dr. Peter, you can start.
Okay, all right. Okay, so this is part 2, and you can all see my screen, yes?
Yeah.
Okay, all right. So the part 2, I want to talk about the pediatric lens surgery and its role in the treatment of angle closure. So of course, we approach this knowing that we do pediatric lens surgery when there's lens opacification. But as is becoming increasingly more popular in the treatment of angle closure in adults, clear lens extraction can be used in this fashion also. This is my financial disclosure, and again, they do not pertain to the content of this presentation. So primary angle closure, so angle closure without prior surgery, with or without glaucoma, is a very uncommon finding in children. So in our own tertiary care center, we published a retrospective review. It was only in less than 5% of the children we see here. There are many etiologies. By far, the most common is retinopathy of prematurity. And these are not angle closure caused by retinal detachment per se, but these are children who have well-treated ROP with retinal ablation, and they develop angle closure. We also see quite a bit of plateau iris syndrome, and lastly, iris pigmented epithelial cysts. We looked at retrospectively our own series in our institution. Turns out that 78.6% of angle closure patients actually had a history of ROP treated with retinal ablation. And they present with this very interesting triad that I'm calling PMAC. P stands for pachyphakia, the relatively thick lens. Usually the anterior posterior diameter is somewhere around 5.5 millimeters. their cornea tend to be small, not super small, but about 9 to 10 in a full-grown child. And of course, they have angle closure, so PMAC syndrome. And looking at children who have retinal ablation for ROP, 10% can develop angle changes and angle closure after 5 years. So this is a real entity, and we know that younger and younger premature children are surviving, and ROP is going to continue to be a big issue, so will PMAC. Now, the surgical options are very challenging. For one, as a glaucoma surgeon, I'll be quite hesitant to do a trabeculectomy for fear of flat chamber and misdirection when you have such a shallow chamber to begin with. Tube shunts are problematic because you don't have much room in the anterior chamber, so you can cause a lot of corneal edema. And cyclodestruction also is very difficult to perform because if you have very poor outflow, then cyclodestruction will teeter between very high pressure to ptysis. So we start to entertain the idea of doing lensectomy with gonial synovial lysis as a treatment for these patients. So I want to present 3 cases with video to illustrate my experience so far. First one is an older child. She's 17 years old, had a history of ROP that was treated with PRP and has developed PMAC syndrome. This is her best corrected acuity. And on presentation, she had intraocular pressure of 31 on all the topical medication that she can tolerate, along with oral acetazolamide. So what I decided to do here was I opened up a conjunctiva as I usually do. Here I'm putting a peribulbar block. You can see that the sclera is very vascularized, so I think some shunting is happening from her PRP. Here I'm placing anterior chamber maintaining cannula. And the first thing I wanted to do was to create the iridotomy to prevent any risk of pupillary block. And here you can see me struggling quite a bit in creating the Refractive because the chamber is just so shallow despite me having fairly high bottle height here. And with a lot of persistence and pushing down on the capsule, I finally was able to create a fairly round rhexis. And this was followed by removal of most of her cortex in piecemeal fashion. This was quite a difficult surgery. And we'll eventually implant a one-piece IOL into the bag. Now, we have previously discussed when would be one time when you definitely don't want to open the posterior capsule or do a vitrectomy. In a child with ROP, because of how friable the retina is, this is one case I don't do it. Now, after the lens is in, I tilt the scope, and with direct gonial visualization, I start to do gonial synovial lysis. And using intraocular forceps, I'm very gently pulling the iris away from what ended up being fairly healthy trabecular meshwork underneath. My approach here is superior, so I'm treating her inferior angle. And the end point is when I see either posterior trabecular meshwork or the scleral spur, or until the iris starts bleeding. When it starts bleeding, I tend to start. Again, here you can see the angles start out closed, and by pulling, we start to open it more, a little bit of bleeding right there. And with this technique, I'm usually able to open up about 210 to 250 degrees of the angle. And this is what the eye looked like at the conclusion of the surgery. So how did she do? I've actually seen her close to about 9 months now. Her visual acuity remained about the same as pre-op, and her pressure came down from 31 on all the medications to 8 on no medications. Thankfully, she can tolerate gonioscopy quite easily, so I can always check to make sure her angle remains open, and so far it has. Here's the second case. This was a very challenging one. It's an 11-year-old girl with plateau iris syndrome. I placed LPI in both of her eyes when she was about 10, and it really didn't change the angle configuration very much. However, the thing that makes me most worried about this girl is that her mother, who also had plateau iris syndrome, became bilaterally blind by the age of 30 under the care of one of my mentors, Dr. Paul Pomber, who is one of the best and most aggressive glaucoma surgeons that I know. And I worry that if Dr. Pomber is not able to keep the mother seeing, then my chances are slim. I've been seeing this child every 2 to 3 months out of fear for her disease turning worse all of a sudden. When she came back to me, her vision was quite good. Her pressure was not high on just a fixed dose combination medication. But it turns out that she had developed a significant iridocorneal adhesion between the 2 visits. So right here, you see areas of the iris just completely stuck to the cornea. And since I perform gonioscopy every visit, this was definitely not there 2 to 3 months ago. So this is definitely new. So I knew I had to do something. And again, I'm going to do a lensectomy first. I place a silk traction suture. Here is my scleral tunnel for the IOL. And because her pupil did not dilate and I worry about it closing on me halfway through surgery, I decided to put in iris hooks here. And this is adds several minutes to the procedure, and I also take care to close all the needle tracks at the end. So here is the iris hooks. I'm performing my vitrectorhexis as I usually do. And with her, the rhexis was also difficult because of how shallow the chamber is. And as I proceed with the surgery, the chamber becomes deeper and deeper. And there, all the cortex and nucleus have been removed. Here, I decided to put in the sulcus IOL because, and with optic capture, so you can see the oval anterior capsular shape. And the reason was because I suspect that even with a PI in place, she was going in and out the intermittent pupillary block. Hence, I did not want to trust the zonules to stay put for me. So I decided to put in a sulcus IOL in this particular case for stability. Once remove the iris hooks and constrict the pupil, you can see how tall her PASs are. And with the intraocular forceps, here I am again peeling the iris away from the angle. And this is one of those slow stop and go techniques. You pull a couple of quadrants, you got to go back in and inject some Helon to see how much progress you have made. So here we go. And turns out that thankfully, because the anterior synechia has not been there for a long time, I was able to restore a lot of her angle anatomy. So here is the inferior angle I'm working on. I will tilt the scope over to the other side. Right here, I'm approaching it from the temporal side to treat her nasal angle. As you can see, the PAS are very, very tall, but they come up very easily. Tells me that this adhesion has not been there for that long. You can see her PI right there. And thank goodness the trabecular meshwork underneath was functioning quite well. And after I have treated all the angle that I feel that I can safely do, I close my incisions the way I usually do, including closing the conjunctiva over the wounds. How did she do? I've seen her more than a year now. Her vision is excellent, and her intraocular pressure in this treated eye is 12 without the usage of medication. This is what she looks like. Some capsular phimosis, her visual axis remain very clear. And here is ultrasound biomicroscopy comparison of the non-surgical eye with a very thick lens and angle closure versus a pseudo-phakic eye with open angles. Now, lastly, a quick case, a 15-year-old male who came to me with narrow angles and high pressure. An outside physician had placed LPI in both eyes. Excellent vision. Maximum topical medications, he presented with a pressure of 38. And on the OCT, you can see that the left eye has lost significant amount of retinal nerve fiber layer. So there's real glaucoma going on. And with UBM, we then realized that he has multiple iris cysts in both eyes, causing angle closure. What's more telling is that these cysts are actually pushed up by the ciliary processes and the zonules. So it occurred to me that if I'm able to lower this diaphragm, perhaps I can open the angle. Now, this surgery is very, very fast-forwarded because a lensectomy technique, I'm not creative enough to have multiple ways of doing the same thing. But you can see that the goniosynovial lysis here occurred quite easily, especially in these light iris patients who haven't had angle closure for very long. You simply tease on the iris, and you can see the trabecular meshwork underneath. Right here. So we're pulling on the iris. You can see the gray band of trabecular meshwork underneath. And based on the video, you can hopefully get a sense that it really didn't require a lot of negotiation to open up the angle. And just like the two previous cases, I treated the inferior angle and the nasal angle. So quite a while after the surgery, vision is excellent. And the treated eye with no medication has a pressure of 9. So we're considering doing a similar procedure in the fellow eye. In our own in-house series, we looked at 11 eyes of 7 patients with about a year follow-up using goniosunicular and lensectomy. All of them had actually improved vision after the surgery. They had decreased pressure at all time points. And in fact, all of them at final follow-up had controlled pressure without the use of antihypertensive medications. So in summary, pediatric angle closure, we think about PMAC syndrome after retinal ablation for ROP, plateau iris syndrome, pigmented epithelial cysts of the iris. Surgical treatment from the conventional glaucoma approach is difficult because of the risk of aqueous misdirection, shallow AC, which is bad for the tubes, and no outflow is bad for laser. Lensectomy and goniosunicular really is a micro-invasive way of restoring conventional outflow in these children. And I find that in my hands, the outcome is best if the synechiae has been there less than 6 months. And it helps us achieve IOP control without using forming a bleb, without putting in any glaucoma hardware, and without exposing the children to laser. So that's the end of my talk. I just want to share 2 free resources. I have a very modest YouTube channel, and if you get a chance to view any of the videos, please leave comments on how the surgeries can be done better so I can improve my own technique. And lastly, my co-authors and I, for the textbook Clinical Decisions in Glaucoma, finally managed to get a free copy of this book uploaded into the American Academy of Ophthalmology website. So please, if you take a picture of this QR code, you will get the free PDF file for this book. And this is written for comprehensive ophthalmologists and trainees. I wish you will share this free resource with your colleagues. And thank you very much for giving me the opportunity to talk to you today.
Thank you so much, Peter. This is a very, very beautiful talk, and about a topic that really doesn't show up that often to our clinics. But let me ask you, the difference in the pathophysiology between angle closure in adults and in children, do you agree that in adults is mostly related to the change in the size of the cataract, and that that the diagnosis of plateau iris configuration can be very challenging, but wouldn't it be more or less diagnostic if you find a narrow angle in a child without a history of treatment of ROP, that this is a plateau iris until proven otherwise?
Yeah, that's a very good question. So I think there's still a lot that we don't know about angle closure in children. The 3 cases I've shown were easier cases because there is more or less identifiable finding. The plateau iris patient had a very thick iris when we measured the cross-section of it. The more interesting question, and we have a panel of distinguished pediatric ophthalmologists, is if we consider every newborn and every young child's eye as nanophthalmic because of the short axial length, and we're dilating them all the time to do cycloplegic refraction, why do we not see pupillary block glaucoma more frequently in these children? I don't think anybody has an answer for that, but my hypothesis is that because they have such formed vitreous, the vitreous pulls on the posterior lens capsule and keep the lens from moving forward and creating a pupillary block as the pupil is coming down from cycloplegia. Now, I don't know if this relationship still exists in a child who had ROP laser done. I think something about retinal ablation changes the consistency of the vitreous, such that with each dilation and reverse of the pupil, their lens can start to move forward. And a lot of the angle closure that we see in post-ROP treatment eyes were in fact intermittent angle closure, causing secondary synechial closure in these children.
Thank you so much. Dr. Hala, did you have a comment? You can unmute yourself, please.
I want to ask Peter something because I'm really interested in glaucoma as well. When you do the goniosunicular on the nasal side, do you have to change your position? You're using a gonio prism, and do you change your position to view the nasal angle, or are you able to do the goniosunicular when you're sitting up?
Yeah, so I literally switched the entire microscope to the temporal side. Yeah.
Okay.
If I have a very skilled assistant, such as Dr. Sayed, when we used to work together, you can get a lot more angle when they rotate the eye using a pair of locking forceps.
Yes.
A lot of the times I don't have that luxury, so I ended up moving myself and not move the eye as much. And yes, I do have to swivel the entire scope. The editing made it look like it happened very quickly, but there's a good 5-10 minutes when you're taking off the knobs and then putting it back on after the scope has been readjusted.
Can I tell you something? I have a tip about rotating the eye if you don't have a good assistant.
Yeah.
That's by placing traction sutures on the superior and inferior rectus muscles and clamping them. And then you can actually rotate them and get more angle done, because I get that all the time when I'm doing goniotomies, and that really helps.
That's an excellent suggestion. I will try that.
It gives you a 360-degree view of the angle.
And also, what do you do when you get bleeding? Like, do you tamponade the bleeding by visco, or do you what do you do?
Yeah, so that's one way. Sometimes by raising the bottle height for a while and just wait, that also stops the bleeding.
Thank you. It's very interesting. Thanks.
Thank you so much. Now it's Dr. Nihal Elshakankiry, and she's gonna share with us her experience in microspherophakia. So Dr. Nihal, please share your screen. Thank you. Yes, we can hear you, and the slides are on.
Okay, so my second presentation is microspherophakia in children and why it is considered as an ocular emergency. Microspherophakia is a congenital anomaly of the lens being small and spherical. It may show variability in the size of the lens and also show variability even in the sphericity of the lens. It is variable. The clinical presentation usually present with shallow anterior chamber and sometimes tremulous iris. And usually in these infants, if you look to the red reflex, it shows a bright red reflex in the center, and then you see a dark halo at the side of the pupil, or circumferentially dark halo around the red reflex. And sometimes when you dilate the pupil, you see just a glistening edge of the equator of the lens, or you see the whole lens equator when the pupil is fully dilated. Sometimes associated with undilatable pupil. If you see here, there is atrophy at the edge of the pupil, preventing it from dilatation. At the edge here, this is fibrosis, and here again, fibrosis of the pupillary ruff. And become the only thing to diagnose microspherophakia when the pupil is constricted. When you go for a UBM, can you see here the anteroposterior diameter of the lens is large, and here a very shallow anterior chamber. Microspherophakia may be associated with large corneal diameters, megalocornea, that is not associated with glaucoma. It may be just a megalocornea as a congenital anomaly. The shape of the cornea may be spherical, and sometimes it is elliptical in shape. Owing to the high sphericity of the lens, it may present with a very high myopia, and sometimes it is misdiagnosed as a congenital myopia. But when you look here to the edge of the pupil, can you see the glistening edge of the lens? Here, when the child took off the glasses, this is the glistening edge of the microspherophakia. And in some children, when the lens subluxate, they usually present with a very high astigmatism that is not amenable to be corrected with spectacles. Some cases are associated with systemic anomaly as Microdani syndrome, small apart from small square hand field and small square, hands and feet. We found that these cases, they're usually short-statured, sometimes associated with premorbid obesity and delayed puberty. Why microspherophakia is considered as an ocular emergency? because it may pop easily and dislocate into the anterior chamber, causing damage of the cornea, here corneal decompensation, or become cataractous and block the pupil, leading to secondary glaucoma, or become cataractous and dislocate into the anterior chamber, or become cataractous and attach to the back surface of the cornea, damaging the cornea. It may dislocate easily into the posterior segment. Like this child, if you look here to the eyes with the magnified picture, the microspherophakia was attached to the iris. Can you see here the patches of iris atrophy? And the very next day, the lens dislocates into the posterior segment. The final picture was like that, atrophy of the iris, and the lens settled in the posterior cavity. Look here, there is pigmentation in the vitreous. This is called Schaffer sign, which indicates the presence of a retinal tear and start of PVR. It may present with all types of glaucoma: primary, secondary, angle closure, pupillary block. And sometimes, owing to undilatable pupil, it may be mistaken as a primary congenital glaucoma, as in this infant. She was diagnosed as a primary congenital glaucoma, and she did a trabeculectomy, and look here, these are the peripheral iridectomy. However, it is not a primary congenital glaucoma, it is secondary to microspherophakia. Maybe you cannot see it here in this photo, but it's very obvious here at the edge of the pupil. So the it was a fade primary congenital glaucoma. Definitely it should fade because the primary etiology is still there. And the treatment is not trabeculectomy in these cases. It should be lensectomy. If the lens subluxate, it may present, as in this child, with secondary angle closure glaucoma. And you see here, these are the sites of iridocorneal contact and complete occlusion of the angle. It may present, as in this child, with pupillary block glaucoma. The lens eyelids are either dislocate in the anterior chamber, blocking the pupil, or pupillary block if the lens is behind the iris, and sometimes associated with severe corneal edema. It may present with very long-standing glaucoma due to pupillary block again, the lens in the anterior chamber, and associated with extensive iris atrophy. And in this child, very long-standing glaucoma, even associated with ciliary staphyloma. Her grandmother, also blind, totally blind from the same condition. Can you see here ciliary staphyloma? And here the lens cataractus and dislocated behind the iris. It may present with total blindness. There is total loss of the anterior chamber, iridocorneal contact, corneolenticular adhesion, the lens in the pupillary area and adherent to the back surface of the cornea. It may present with another type of glaucoma due to congenital aniridia. This is a microspherophakia cataractus associated with secondary glaucoma due to congenital aniridia. Not only this, it may be associated with congenital aniridia, congenital cataract, and also keratolenticular adhesion. So all types of glaucoma may be associated with microspherophakia. How to treat? The first line of treatment actually is not, for me, in my opinion, is not a peripheral iridectomy, because complication will definitely occur. Here, the lens dislocate into the anterior chamber and cause damage to the cornea. In my opinion, once you diagnose microspherophakia, the first line of treatment is lensectomy. I prefer to do lensectomy through two corneal wounds, again using MVR knife 20 gauge. And then I make a tear in the anterior capsule, and then I go with the Rexis 25 gauge to perform anterior Capsulorhexis. I sometimes hook the capsular bag with an iris hook to stabilize the lens, and then I go for hydrodissection hydrodenylation, irrigation aspiration, and then the capsular bag, eat it up with a cutter, perform anterior vitrectomy, and then finally I close the wounds. Sometimes while penetrating the anterior chamber, I penetrate the lens, and then through this tear, I make a rhexis in the usual way. And then complete irrigation aspiration, remove the capsular bag, perform vitrectomy. This is very simple and easy technique if I have the lens in place and it is not mobile, and I have still the zonular attachment is there. It is easy to go for the anterior rhexis and irrigation aspiration and eating up the lens and performing vitrectomy. But there are some difficulties during surgery, how to overcome. To start with, when I try to make anterior rhexis, when you try to make the initial tear, sometimes you go for a tear with the cystotome and it never tears because it is associated with thickening of the anterior capsule. So what to do in these cases? When you try first with the cystotome to tear and it never tears, don't pull or push because you're going to dislodge the lens. Maybe it's going to be pushed to into the posterior segment. In these cases, I go with a special forceps and I hold the anterior capsule, fix it with the forceps, and then with the micro scissors, 23 gauge, I make the initial tear and then continue the surgery, anterior capsulorhexis, and then continue the surgery. And in some cases, when the lens is totally mobile, in these cases, I not only fix the anterior capsule and make the initial tear with the cystotome, no, I keep on holding the lens with the forceps and do the anterior capsulorhexis while holding with the forceps in order to stabilize the lens and make a sort of a counter pressure to perform easily the anterior capsulorhexis. And then complete the surgery in the usual way. And finally, close the wounds. What if the lens is subluxated? Still, I don't go for posterior approach and a pars plana lensectomy. I don't like to eat up the lens behind the iris without seeing it. So, how to do? How to perform the surgery? After anterior capsulorhexis, I use an iris hook to hook the anterior capsulorhexis and centralize the lens. There is advantage of this actually iris hook. It makes the anterior capsule in the form of a tent, separating the capsular bag from the cortex. Through this tent, I go with a cannula and inject and perform a perfect hydrodissection. This will facilitate the irrigation aspiration. It's going to be very simple and easy. It won't take seconds in your hands. And once you are in, never out until you finish irrigation aspiration. And there is another advantage. When you remove the iris hook, can you see here the zonules? They are still there. Here with magnification, the zonules are still there. It means that vitreous did not prolapse during irrigation aspiration. It means that, what does that mean? It means that there is complete stabilization of the iris lens diaphragm during irrigation aspiration. And this is very important because excessive fluctuation of the anterior chamber may predispose to retinal detachment in the future because they have pathologies in the retinal periphery and the vitreous space. And then you complete the surgery again in the usual way, vitrectomy, capsulectomy, and vitrectomy. So the direction of the hook, how to centralize the capsular bag, it depends upon the direction of the subluxation. So you can use a Sinskey hook to pull the capsular bag and hook it like that and centralize the lens, or you can use a Y-shaped spatula in order to push the rhexis and stabilize the lens and centralize the lens and complete the surgery, as I told you, in the usual way. A last issue concerning the surgery, if you have a large spherophakia, after anterior capsulorhexis, You have here a beautiful zonules, and it's stable, and it is in place. After irrigation aspiration, you have a beautiful bag. Don't ever think to leave it as a secondary support as if you are performing congenital cataract. No, in these cases, you have to go again and eat up the capsular bag with your hands and leave the child without a capsular bag. Why? Because I tried for some time to perform, this is a microspherophakia, it's a large one. Can you see here the edge of the lens? And after irrigation aspiration, I did perform Posteriorhexis and Anterior vitrectomy, and I found it's a beautiful capsular support. Why not to leave it for future secondary IOL in sulcus? What happened a few months after surgery? Complete shrinkage of the capsular bag, because and elongation of the zonules, extensive elongation of the zonules, because the zonules in the microspherophakia, initially they are pathological. They couldn't withstand the capsular phimosis of the bag, which normally occur with the case of a congenital cataract. And here another case, this is a large microspherophakia, this is the edge of it. Here, after performing anterior capsulorhexis, and after performing posterior capsulorhexis, we found this beautiful support. And this is the edge of the lens here at the pupillary area. Again, few months after surgery, same picture. So we had to go for vitrectomy in order to eat up the capsular bag and to clear the visual axis. After surgery, immediately we found that the anterior chamber becomes deep, and we fit the babies with aphakic spectacles. And in older children, where they suffer from microspherophakia, here a dislocated one and a subluxated in the other eye, we can implant iris glow lens as a secondary procedure. But they should not be glaucomatous, and you have to wait for some time and be sure they will not develop glaucoma after surgery. This is an example of long-standing glaucoma, pupillary block glaucoma here, before surgery, here at conclusion of surgery, immediately after surgery, and few months after bilateral lensectomy. The pressure was controlled in the left eye, and we were able to save the right eye. And this is her brother. Of course, we found him that he was presenting with high myopia, but without glaucoma here before and immediately after surgery, and 1 year after surgery, he didn't develop glaucoma. Finally, to conclude, microspherophakia may present with high myopia that is confused with congenital myopia, high ambulogenic astigmatism that is not amenable to be corrected with spectacles, may present with complications as anterior or posterior dislocation of the lens, and may present with all types of glaucoma, congenital or acquired, primary or secondary, angle closure or pupillary block. And that's why it is considered as one of the pediatric ocular emergencies that have to be dealt immediately with lensectomy. And thank you very much again for your kind attention.
Thank you very much. This is an amazing presentation, Dr. Nihal. I have a lot of questions for this, but I want to hear comments from our speakers. Dr. Hala, do you have a comment about this very interesting topic, the microsphere?
Yes, actually, I have a comment and I have a question. So I'll go with the question first. So at the end of surgery, after you've removed the lens, do you do a gonioscopic examination of the angle to see what happened in the angle after you remove the lens? Like, does the iris diaphragm fall back? Are there synechia already? Is it a chronic angle closure, glaucoma, or is it something else?
Yes, actually, we go as a teamwork. Professor Nader Bayouming with us in Alexandria University. I do the lensectomy, and then he takes the case. He goes for everything: goniotomy, UBM, fundus exam, pachymetry, intraocular pressure, and we follow these cases for years. Because some cases, they don't have glaucoma, but they have angle anomalies, congenital angle anomalies too. We follow these cases for years, and some cases develop glaucoma maybe years after surgery.
Okay. So my comment on the surgery is I think it's wonderful. You're really talented, and it's a great, elegant surgery. It's just that I think that I would not go to such lengths in preserving the bag, and also using iris hooks and all that. Since I'm going to remove the bag, if I would do that if I was going to implant an IOL in the bag later. But if I'm not going to preserve the bag and I'm going to do an anterior vitrectomy, I would go with a much simpler technique, like spear the lens for support, do a lensectomy, whether anterior or posterior approach, and then do my vitrectomy. I think that this is really a lengthy procedure. It's great surgery, though. It's beautiful to watch. Thank you.
Dr. Peter, do you have a comment about this interesting case?
There's the surgery was, I think I had to pick my jaw off of the floor after watching it. It was so wonderful. And I don't have that much experience dealing with microcerophakia, but I'm wondering, Professor Nihal, what is your preoperative workup for these children in ruling out syndromes that can increase peri-anesthetic risks? Do you have them see a geneticist, or is it just a pediatrician, or as long as the pediatric anesthesiologist is fine putting the child to sleep, you feel comfortable doing the surgery?
Yes, of course, this is a teamwork. It's not only me. So I have Professor Nader, specialized in congenital glaucoma. I have special pediatric ophthalmologists who actually put these babies into sleep. He's been working for me for more than 15 years, so he's acquainted for these cases. I have special pediatrician who is acquainted to see all the syndromes and rule out all the syndromes, and geneticists. So it's a sort of a teamwork to rule out all the anomalies that may be associated and the syndromes that may be associated with congenital. The last case actually we did that was just 1 month ago. She had a pulmonary stenosis, and she had to go first for her surgery before going to the bilateral lensectomy. So it's a sort of a teamwork. It has to be there in order to perform a good service to pediatric ophthalmology.
Thank you very much.
And as a follow-up question, I'm sorry, I have this is just such a fascinating topic. Do you routinely do genetic testing on those children? Do you only do it if they have a family history? And how often are you finding a disease-causing variant in these children?
Concerning the syndrome, no, it's very common to have, of course, syndromes with microcerophakia. And it's very common to have the Weill-Marchesani syndrome. We see it frequently. We made more than 300 cases, or 350, or even more. And it's very common to have this syndrome with the microcerophakia.
Very interesting. Well, the question is
sorry to interrupt you. Another irrelevant question. Like, how do you get these images, like, from as if they were like taken from behind the iris?
These are snapshots. Actually, these are snapshots from surgeries. I'm not a good I'm not.
I was gonna ask, like, you look like you're a great photographer too.
Primitive actually in editing the videos, so I just take snapshots from the surgery and I put them behind each other in order to speak slowly about each step. So this is actually a drawback that I don't go for a good editing like, for example, Professor Hala or Dr. Peter. So it's a sort of snapshots from surgeries.
It's a great way. It's a great way to present the surgery.
Thank you.
So the discussion is very interesting, but I'm really eager also to hear Dr. Hala in her last presentation. So please, Dr. Hala, start sharing your presentation. The discussion is very interesting. I'm really enjoying it. Dr. Hala will speak about a very interesting topic, actually, very wide spectrum, persistent fetal vasculature. So we are eager to hear the experience of Professor Hala for this.
So, thank you. Shall I start? So persistent fetal vasculature is a congenital anomaly caused by failure of the fetal hyaloid vascular complex to regress. According to the location of the vascular abnormality, it may be either anterior, posterior, or combined. The anterior type is caused by failure of the tunica vasculosa lentis, either partially or completely, to regress. And there are like quite a bit of presentations that are very different. So it can present as a network of blood vessels behind the posterior capsule, which is the persistent tunica vasculosa lentis. It can also present as a Mittendorf dot, which is the anterior terminus of the hyaloid artery, a central retrolental membrane, a completely vascularized, complete retrolental membrane with vascularization. It can also, in combined form, present with a stalk that is attached between the posteriorly to the optic nerve head, anteriorly to the back of the lens, enclosing the hyaloid artery. This is a complete retrolental membrane that is very thick, and it's also attached to the ciliary processes and pulling them centrally. Again, extreme elongation of ciliary processes and centrally pull. This is an anterior persistent fetal vasculature with other anomalies. You can see hair-like processes extending from the pupil, from the iris into the pupil and attached to the anterior lens capsule. There is also corneolenticular touch in the center and a very shallow anterior chamber. These are ultrasound courtesy of Dr. Hala Elhilali. You can see the anterior persistent fetal vasculature with a dense retrolental membrane. When the posterior part of the hyaloid artery remains or fails to regress, you can either get a Burgmeister papilla, a stalk attached to the optic nerve head. And when the glial, both the glial and the vascular components of the stalk exert peripapillary traction on the retina, they tent up the retina and cause tractional retinal detachment. This may be accompanied by retinal folds or retinal dysplasia. Other retinal and disc anomalies may exist, such as the morning glory syndrome. This is the picture of the brittle star, characteristic brittle star appearance of the retinal folds when the stalk pulls on the peripapillary retina and tents the retina anteriorly. Again, this is a stalk adherent to the disc. It's sometimes very difficult to get the stalk. It can be very fine and needs an oblique orientation of the probe, tractional retinal detachment, retrolental membrane with tractional retinal detachment, and disc glaucoma. There are sequelae to both types of persistent fetal vasculature. There's always traction on the ocular surfaces. So when you have a stalk, it causes anteroposterior traction and hinders the axial elongation of the eye. If you have a retrolental membrane that's attached to the ciliary processes, again, it's exerting circumferential traction, preventing the circumferential growth of the eye and the anterior segment components, especially the cornea. Other sequelae include glaucoma, retinal detachment, and dense amblyopia. Chronic angle closure developed because of contraction of the fibrovascular membrane behind the lens, which pushes the anterior lens diaphragm forward, resulting in peripheral anterior synechia and posterior synechia. So a good question is, why bother with these cases? They have a bad name for poor visual outcome. Actually, they are a very wide spectrum, and we shouldn't put them all in one basket. And many varieties of the anterior type end up with useful vision up to 6/18 or even better. It's the posterior type that really have a poor visual outcome, but we need to bother with these cases, not just for useful vision, but also to halt the traction that may result in the sequelae and the complications and end up with glaucoma, retinal detachment, or a blind, painful eye. Many surgeons, or the majority of surgeons, prefer an anterior limbal approach in dealing with persistent fetal vasculature because they worry about the fact that the peripheral retina may be anteriorly displaced because of the traction on the ciliary processes, and that going through the pars plicata may end up by creating breaks in the peripheral retina. And actually, studies have proven that the rate of complications are similar in both approaches. So I'm going to go through a variety of cases that vary in severity. So, this is a case of a mild anterior persistent fetal vasculature with a central retrolental membrane. And in this case, I do use the pars plicata approach, but I place my sclerotomies 1 to 1.5 millimeters from the limbus. And once I'm in the lens, again, we aspirate the cortex. And after removing the cortex, here I prefer to remove the central part of the anterior capsule first before dealing with the posterior capsule and the retrolental membrane. After aspirating the cortex and the, I can actually maybe go a little bit faster here. So actually here, after finishing the anterior capsulectomy, it's sometimes difficult to open the dense retrolental membrane with the vitreous cutter. And in these cases, you may need just to make a tiny or small incision first with a sharp instrument like the MVR blade. And this is followed by continuing or enlarging the opening with the vitreous cutter. You can see here that at the back of the membrane, there's a tiny blood vessel. And this goes on and you can enlarge your opening. This is another case where there is a dense vascularization of the retrolental membrane. And again, there's a small artery attached to the back of this membrane, but I'm enclosing this video to show you that these vessels hardly bleed with any significance. So I've never really had to needed to use any cautery prior to removal of the membrane. This is a stalk, and it's quite a dense stalk that is attached to the back of the lens. And here, after removal of the anterior and posterior capsules, I'm going to start dealing with the stalk. There are two ways to deal with it. One is with the vitreous cutter, and you'll see that it has a really dense fibrous plaque at the anterior terminal of it. So I'm supporting here this plaque with my irrigation cannula, and I'm debulking the plaque with the vitreous cutter. It took quite a bit of time to debulk. And you will see that suddenly there will be a release of the stalk from this plaque. And when that happens, you will find that the stalk will retract backwards, and I will continue to remove the the fibrous plaque and do the vitrectomy. This is another stalk where it was a much thinner stalk and a much thinner fibrous plaque. And in this case, after removing the anterior and posterior capsules, I chose to remove the stalk actually with scissors. It took, again, several cuts through the stalk to sever the attachment between the stalk and the fibrous plaque. But finally, I was able to sever that attachment. And then I continued. So there you go. Then I followed up with the vitreous cutter. I trimmed the anterior end of the stalk, and then it fell back. It retracts all the way to the optic nerve head. And I only do these cases if there is no tractional retinal detachment. If they do have tractional retinal detachment or other anomalies, I refer them to the retinal surgeon, of course. This is another case where there was extensive traction on the ciliary processes and caused by the central membrane. And I'll really go a lot faster here to show you that after removal of the plaque, the central membrane, you will find that the ciliary processes will retract, but this is really not enough. After removing completely the membrane, you have to cut. I'll go in with scissors and cut the attachment, the membrane between the ciliary processes, and you need to do that for 360 degrees so that the ciliary processes retract back completely, and you don't get recontracture of the membrane between them, and again, an elongation and moving centrally of the ciliary processes. So these are 23 gauge scissors that I'm using circumferentially to cut the attachment between the ciliary processes, and you'll see them retract even further. I'm going to cut this video here and show you the last one. This is the severe type. You can see the angle closure here. The angle is completely closed. And actually what you see circumferentially right inside the limbus is the root of the iris, because the retrolental membrane is exerting such enormous traction on the root of the iris and the ciliary processes that you can actually see the angle. So in this case, I chose to do an anterior approach. I didn't want to go through the pars plicata in this case. So I used blunt dissection with viscoelastic to sever the corneolenticular attachment, which was present in the center of the cornea, and also to cut or remove the synechia with this blunt dissection. This is the vitreous cutter. There was hardly any lens left. That was all a very, very, very thick retrolental membrane. You can get an idea of the thickness of that membrane, and I used my cannula, irrigation cannula, as a second hand to push the iris back, dilating the pupil even further to get as much of the membrane as I could. And after removing this membrane, you just can't leave the membrane still attached between the ciliary processes, otherwise it will contract again. So you have to go again with the scissors circumferentially to cut the membrane between the ciliary processes all around. You can exchange hands and do it with the left hand. This is the final appearance. The central corneal opacity pre-existed, and it was caused by the corneolenticular touch. So I'll go. So postoperative complications, we do expect a lot of them: synechia, detachment, visual axis opacification, glaucoma, vitreous hemorrhage, and a more than normal inflammatory response. I learned a lot of lessons by doing these cases. They're challenging, and I like the challenge, but they also have different presentations and different prognoses, so we shouldn't give up on them. There are different reasons for doing surgery for them, not just the visual outcome, but again, to halt the traction that is existing in these eyes. We have to be aware and ready to deal with complication. And just one last tip, you have to be really on good terms with a retinal specialist, and that's why I'm married to one. Thank you.
Thank you, Dr. Hala. Thank you for very nicely demonstrating such a very challenging situation. And I want to ask you, which cases can undergo intraocular lens implantation?
Okay, so definitely not the posterior types, or the ones where you have a corneal diameter that is really small, less than 9 millimeters, but those with the mild anterior types, where you have just a small central retrolental membrane, no traction on the ciliary processes, definitely. And when you can have a good sulcus to implant the IOL, this is the patients that I can implant the IOL in. And I have some really cases where I actually have some like 6/12 vision or 0.5. I'm very happy with them. Okay.
And Dr. Nihal, do you have any special comment regarding persistent fetal vasculature cases? Can you unmute just yourself first?
Well, my comment is beautiful presentation, Professor Hala.
Thank you.
Thank you.
And Dr. Peter?
So I'm actually very fearful of persistent fetal vasculature. I would approach and do the surgery myself if and only if I don't see stretched ciliary body through the edge of the lens, and being absolutely sure that ultrasound does not show any traction or retinal detachment. Now, I don't know if I will be a little bit more brave if my access to a pediatric retina specialist is not so easy, because I do have a very good colleague here. She only does pediatric cases. So when in doubt, I figure I'll have her do the case, and if the retina starts to come off, she's in a better place than I am in reattaching it to lasering any detachment. That said, the couple that I have done all have gone well, and we do know that from infant aphakia treatment study if the cornea is not smaller than 9 millimeters, and if you don't see stretched ciliary processes, their visual outcome can be comparable to the rest of the group, albeit they have a slightly higher risk of needing post-operative reoperation after the surgery. So that is, and one other thing, I think I want to give Dr. Syed the credit. One of the papers that we wrote together when he was here at Bascom Palmer was looking at the predictive value of ultrasound in making the diagnosis of non-obvious persistent fetal vasculature. It turns out that the positive predictive value was quite high, about 80 to 90%. So all my cataract patients, no matter how normal they look and no matter how sure I am about the diagnosis, I always get a D-scan just to be absolutely sure that I'm not missing a stalk in there somewhere.
Yeah.
Okay. Do you consider some cases as inoperable if you have a microcornea along with severe microphthalmia? Yeah, Dr. Chang?
Yeah. So anytime, and I think the panelists will agree, if we're going to declare something inoperable, you never want to do it by yourself. And my approach is I would, so we call ourselves the ABC trio. You know, I have Dr. Abu Shusha here, who is pediatric cornea, Dr. Barakal, who's pediatric retina, and my last name is Chang. So the three of us will see the patient together. If 2 of the 3 decided that surgery is going to cause more harm than good, then we have that conversation with the parents. Yeah, but there are times where the retina is so disorganized and it's a unilateral case. Our concern is you do something heroic and the child ends up getting persistent postoperative inflammation. And what happens if you end up having sympathetic ophthalmia in your only eye? I think that is a topic that it's everybody really is firmly in their minds, but sometimes we don't talk about it enough with the parents of our patients.
Okay. So I think we exceeded 2 hours now. Dr. Muhammad, so you want to add something? Unmute.
No, I just want to express my gratitude for all of you that, you took this precious time from your families and from your busy schedules to conduct this meeting. And I think that these meetings help us build bridges and may ignite the fire in us and all of us to take this further and collaborate on research projects and exchange knowledge and experience. I learned so much today, and all the talks were wonderful, and I can't be happier for being a part of this amazing group today. Thank you so much.
Thank you.
Thank you, Dr. Muhammad. Dr. Ayman?
Thank you, Dr. Syed. Thank you. And actually, I would like to give the credit actually to Dr. Muhammad Syed, because this webinar actually was the initiative was from Dr. Muhammad Syed. So I'd like to thank him for this initiative, and of course, thanks Dr. Peter and Dr. Hala and Dr. Nihal for accepting our invitation to proceed this amazing webinar. I learned a lot, and I'm sure that the audience enjoyed this very much. So thank you very much.
So
Dina?
Unfortunately, we have to conclude. And I'd like to thank our speakers, Dr. Chang, Dr. Hala, Dr. Nihal, and my co-moderators, Dr. Ayman and Dr. Muhammad, and actually all the wonderful audience who participated and contributed to the success of our series of previous and hopefully coming webinars. I'd like to introduce the coming international webinar, which will be on pediatric glaucoma surgery, featuring a great collection of experts from around the world, and will cover all types of pediatric glaucoma surgery and lasers. And I want you to follow our website and Facebook page. And the meeting will be on Saturday, June 6th at 8 p.m. Cairo time. And stay tuned. We'll send you the login details later on. And thank you so much. And sorry for keeping you up late here in Cairo. And have a wonderful day. Thank you again, everyone.
Thank you.
Thank you.
Guys. Thank you, Peter.
Honor. Thank you.
Thank you. Thank you, Muhammad. Thank you very much.
Thank you so
Bye.
much. Bye-bye.